Hello, dear friends. Welcome to our online weekly webinar with specialists of IVMed Clinic. So today we have a special topic. We have a special topic today, and our topic is pronuclear transfer as alternative to egg donation. We decided to choose this topic because a lot of patients ask us about that, and it's quite a special procedure, and not every embryology laboratory can do that. So we decided to invite our special speaker today, Birol Aydin, Director of IVF Laboratory at IVMed Fertility Center, senior embryologist, and official expert of Society for Human Reproduction and Embryology. Just to remind you that we have an active chat, so you can ask all your questions during the presentation and after that. So after the presentation, we will answer all the questions. And to remind that this webinar will be recorded, and also you can check the record of this webinar on our YouTube channel. So we will start. So please, Birol.
Hello, everyone. We will try to talk today about some advanced technique. Actually, it is quite new in the IVF field. And it is not just additional techniques, it is totally new IVF process and from the beginning. So I will try to share a presentation. So I will try to explain. Of course, pronuclear transfer, our topic is alternative for egg donation, but it's not just alternative to egg donation. Also, as I said, it's a complete process, a new process for the IVF. So we can solve different problems depending on site quality, embryo development problem, embryo aneuploidy. So it's not just actually to alternative to egg donation. Of course, this is the main reason why we developed this process, but mainly it's helped to many patients for different questions. Okay, so of course, why we try to build such technology, first let me try to explain. Because when aging is increasing, and especially for women, of course, quality of oocytes and quality of follicular level is decreased as well. So then we cannot find enough energy inside of oocyte to feed oocyte till from the fertilization till blastocyst stage. So we need more energy and of course better cytoplasmic activity and mitochondrial quality. So what is the main question for the mitochondria in the oocyte? So of course the oocyte has the largest number of mitochondria and mitochondrial DNA copies in per cell. And these are significantly more than all other cell types. So that's why mitochondria is the critical point for the energy requirements. The mitochondria and the oocyte have two major roles. First is, of course, is trying metabolic regulation in the oocyte, and second, of course, is mitochondrial DNA is making for future developing offspring. So during the follicle recruitments, mitochondrial mass increased from 6,000 mitochondrial DNA to 200,000 copies. So that means for each copies may have some mutation or deletion, and this of course directly affect quality of embryo and embryo development. So if we talk about fully grown human oocyte, of course mitochondria has very critical roles, because mitochondria is responsible for the energy source and of course immaturity of the egg, which we have often to see for high age women. We have many immature eggs. Even if we get several follicles, mostly we get very low quality of oocyte or immature oocyte. So this is the reason, because of mitochondrial activity is low. So after the fertilization, oocyte mitochondria has kind of structural change, and of course this can affect the somatic quality on the blastocyst formation. So oocyte mitochondria need really good potential for the early embryonic development. This is the first reason. And second reason, as we are calling glycolysis, which need for the maturation of the oocyte, while we have maturation problem for the most of the patient. That's why oocyte is not getting fertilization process. So we mostly cancel the cycle. That is the main reason, because of mitochondrial DNA support is not enough. And second station, so we have cleavage embryos, but embryos are not going to blastocyst because still we have a lot of mitochondrial DNA mutation and deletion. That's why there is no blastocyst, or even if we have blastocyst, it's a very low quality of blastocyst. So if we talk about egg quality, of course, that egg quality depends of cytoplasmic activity, depends of quality of polar body as carrying up all DNA process, and perivitellin space, which is making balance between oocyte wall and cytoplasmic activity, which is exactly protecting the oocyte, and cytoplasmic activity, which is carrying up mitochondrial DNA and all other organelles, which is giving energy support to oocyte. So what is the main solution if we have low oocyte quality? Of course, this donation, egg donation is the easy solution always, but of course, still every patient have right to carry up their genetic potential, their genetic material. So that's why we need to create an additional advanced technology which can be alternative to egg donation. So why egg quality can be poor? Of course, maternal age is the number one. So polycystic ovary syndrome, mostly many polycystic ovary syndrome patients cannot get easily pregnancy, or even if we get many oocytes, they have poor quality and they don't have enough number of blastocysts or euploid blastocysts. So ovarian reserve, of course, if ovarian reserve is dropped, so mostly quality of oocyte as well. So genetic factors, this is one of the important. If especially have some kind of mitochondrial disease, endometriosis, always endometriosis can affect quality of oocyte, and mostly if there is an endometriosis, we get high rate of immaturity. And of course, mitochondria in an egg cell breakdown. So if there is a mitochondrial question, this is the main reason why we try to build this technology. Of course, oocyte is not developing after the fertilization till the blastocyst. So, of course, it's increased maternal age, mitochondrial DNA mutation and damage also increasing. Some mitochondrial function are changing, and of course, metabolic activity is changing, and which we are calling ATP, the main energy for every biological cell decreased. That's why oocyte cannot find enough potential energy to get high quality of embryos. So as we saw on the graphics, so depends of age, of course, live birth rates is dropped dramatically, and also depends of age, as we see between patient and donor eggs. So there are huge difference. While we have donor eggs, we have better quality and high live birth rate, while we have patient with maternal age, live birth rate drop. So if we talk about aging and mitochondria, of course, loss of mitochondrial function, it is the one of the reason. Mitochondrial DNA mutation and deletion, so energy production, oocyte maturation, aneuploidy rate increasing, of course, nuclear spindle activity problems, embryo cleavage and cytoplasmic fragmentation problem, embryo implantation potential problem, and ATP production problem. So all of these questions are giving right to do pronuclear transfer or spindle transfer to achieve high quality of embryos. So if we talk about mitochondrial treatment, so we have, if we have unaffected father and affected mother, So mostly we will find affected child after the fertilization if there is a mitochondrial disease. But if we have affected mother and unaffected mother, so then child mostly unaffected. So as we saw in this graphs, so we get all mitochondrial disease mostly from the woman. So oocyte potential, oocyte quality, oocyte mitochondrial activity is the priority for us. So why egg donation need alternative? Basically, egg donation need alternative because most of the parents, almost let's say 90%, firstly, of course, they prefer to carry up their own genetic material. They want to be more motivated psychologically, and this is their social and genetic rights. So that's why egg donation need an alternative. And another things, of course, if there is some potential on patient eggs, of course, priority should be for the scientist or embryologist or IVF specialist. Priority should be to use their own material, and pronuclear transfer and spindle transfer is giving good alternative for this. And also egg donation is an alternative because after the pregnancy, there are psychological process also. And for most of the couple, most of the women, to know that they are carrying up their own material is much more motivated as well. So there are two alternatives for the egg donation, spindle transfer and nuclear transfer. Now we will try to quickly talk about both. Spindle, mostly before the fertilization, just we got oocyte from the pickup and just we try to clean with a special enzyme cumulus cells, cumulus complex cells, and just with special software we can find the spindle. Spindle carry up all genetic potential of the egg. So to determine spindle, it's almost impossible to see with the regular microscope or objectives. Needs special software for that, and it's not common everywhere. Of course, this software has high cost and also needs special training and education for the embryologist to use. So if we talk about spindle transfer, the replacement of the entire cytoplasm of poor quality of egg. So we have eggs with poor quality from the patient, and from other side we have high quality eggs with cytoplasmic activity and good quality of spindle from the donor eggs. So basically what we are doing, we just switch spindles between donor eggs and patient eggs. So patient has, in this case, their own genetic material inside of high quality of cytoplasmic activity and high energy potential of donor eggs. So it means these donor eggs actually carrying up patient genetic material has big potential for the embryo development. So we are using special techniques, special solutions. So just we are getting from patient egg and donor egg at the same time. And we open the zona pellucida from the donor egg, which is protecting cytoplasmic activity. We just enter small biopsy pipette and we just take out spindle of the patient, which carry a patient genetic material, and then just we transfer to inside of high quality of donor eggs. In this case, of course, 99% of the DNA activity is a phenotype and genotype from the patient. Only 1% of mitochondrial DNA will come from the donor eggs. If we talk of advantage of the spindle transfer, of course, it will protect the patient from the mitochondrial disease. There is no possibility to get mitochondrial disease, and it's a big chance to get healthy children, of course. And the study suggests mitochondrial donation could prevent more than 12,400 women in USA, because it's most popular in USA, from transmitting of mitochondrial disease. So that means at least 770 babies could be saved from this disease annually. This number could be increased in Europe and Asia as well, because there are not enough publications for that. Material spindle transfer has been tested on human eggs. and method led to development of the blastocyst, of course, and we have high quality of blastocyst and aeuploid embryo layer. Of course, there's less mechanical and morphological damage during the spindle transfer. What about pronuclear transfer, which I prefer more than spindle transfer actually, because there are different kind of advantage. So firstly, while we have spindle transfer, still we don't have fertilized egg. So still after the spindle transfer, we should fertilize this egg and we should wait still fertilization. But for pronuclear transfer, we already have fertilized oocyte. So basically we have fertilized oocyte with patient oocyte and sperm, and from other side we have fertilized oocyte, donor oocyte from patient sperm. So basically we just exchange pronucleus which carry up intended parents genetic material. We just transfer them inside of the donor eggs. So we give them big potential of the energy and mitochondrial activity. In this case, again, 99% of the DNA is coming from the intended parents, and only 1% of mitochondrial DNA is coming from donor. So it's basically same situation what we do for the spindle transfer. We just open with the secure laser, the zona pellucida. We just receive pronucleus and we transfer inside of high quality of donor eggs, and we follow embryo development. So advantage of the pronuclear transfer, of course, as I said, there is no risk for fertilization because our eggs already fertilized and we do the transfer between zygotes. According to our statistic, better blastocyst outcome from the pronuclear transfer than spindle transfer. Of course, as spindle transfer, it also helps to get healthy children from the mitochondrial disease. Of course, technique and mechanical micromanipulation request high experience because this is traumatic method. So if there is a non-experienced person, so it can get degenerate embryos or oocyte. So it is just a quick video. I will try to show how we are aspirating pronucleus. This is intended parents, like from patient pronucleus. We just carefully remove from the patient eggs and we just transfer to donor eggs. Actually, it seems traumatic, but we have to understand, of course, oocyte is a like egg oocyte or biological material is a like an organism. So they are also strong and they can recover themselves back. If we use technique like under experience and high quality, oocyte will not get damaged. So after this removing, after 1 or 2 hours, oocyte will come back as compact position. So if we talk about result of our experience, so what we did, we make a different group of IVF programs. So, and we check the IVF outcome. So first group was IVF program to study the feasibility of the pronuclear transfer to prevent mitochondrial DNA disease transmission from mother and child. So first group, we just use only who has mitochondrial disease. Second group, we get only cytoplasmic activity problem. Third group, who has really low airflow blastocyst rate after NGS or PGT. And last group, who has high H factor. So in the first group, we got 18 patients with low ovarian reserve, so who has minimum 2 dominant follicles, age up to 35. Second group, 15 patients with low blastocyst rate, like IVF history before, and high aneuploid blastocyst rate during the previous cycle. There is no age limitation. Group 3, 16 patients with unexplained infertility up to 4 IVF trial with stimulation. There is no age limitation as well in this group. And group 4, 6 patients with mitochondrial disease. Also, there is no age limitation in this group. So, if we check about pronuclear transfer, which we use oocyte and ICSI. So, as we saw, 80 oocytes, so we got 76 embryos and fertilization. 168 from second group, 166 third group 204 and 196 are almost up to 95% of fertilization rate after the manipulation, micro manipulation. So that means system is and technique is secure for the oocyte quality and that there is no damage. So if we check cleavage rate and degeneration rate, we found around 70% average cleavage rate from each group and only 2 to 3% of degeneration rate, which is very normal even for regular fertilization. So if we check the blastocyst rate, even for the group 3, up to 35 years old, and group 1 up to 35 years old, even we got up to 45% of blastocyst rate, which they never have in their IVF experience and their treatment any blastocysts. So this is a huge number of the blastocysts. So if we check about aiploid rate, aiploid blastocyst rate, like a usual donor embryos, donor eggs, so almost 70% of aiploid rate, which is really high and impressive. So what about pregnancy rate and life birth? So techniques start to use actively from March 2019 and first embryo transfer done in IVMed clinic. Number of embryo transfer are limited because of endometrial factors and some personal reason. Patient try to postpone to transfer or someone trying to make a pool and to get more embryos. Number of embryo transfers are 24 patients after the pronuclear transfer. Number of the ongoing pregnancy are 11. So already that means 50% of the patient get pregnant after this pronuclear transfer. 2 patients lost the pregnancy, 5 weeks and 7 weeks. So 3 patients already have live birth in China and 2 patients in Ukraine already has healthy and 3 parents confirmed baby. So we are working on the publication, scientific publication process. So as IVMed clinic, of course, our international department is giving you support. So even with pronuclear transfer, still you have possibility to get quick pregnancy and our international department always will support you for all the process. So IVMed clinic and our team, embryology team, always will give you scientific advice and support as well as from online or from email or from quick calls or if you visit our clinic. So this is our team. All of them is working on the project from the international department to IVF specialist and embryology laboratory. So thank you very much for your time and I'm ready to get your questions.
Thank you, Bro, for your presentation. I need to check our chat if we have questions. So the first question, hello, I'm 34, I have mitochondrial disease. We tried IVF with pronuclear transfer, donor was 24 years old, but embryo stopped in development. Do you recommend to try one more time or doesn't, or it doesn't make any sense? Please, Bill.
Okay, so exactly pronuclear transfer is not like we can get immediate response. Of course, they need to try more because it's not only about mitochondrial disease or about cytoplasmic activity. Sometimes we just don't get high quality of pronucleus from the patient. So if pronucleus still have genetic damage, so this embryo will not develop. This embryo didn't develop from the donors, what they did, because they had in this cycle some genetic disease on the pronucleus. But that means not next cycle again they will have this. So one cycle they can have, but next cycle they will not. So mostly for such situation, I suggest to make pool, at least to get 5-6 embryos to increase the chance. So different stimulation to get 2-3 eggs each stimulation and to collect them. So it is still possible even we can work on the frozen fertilized egg. Even if they are not in so IVMed anywhere else, they can just carry up their frozen eggs and we can work for pronuclear transfer.
Yeah, thank you for your answer. Our next question is, if I am older than 40 years old, but still good ovarian reserve, can I do pronuclear transfer?
Of course, that is big advantage. Actually, there is no age limitation on pronuclear transfer. It's only point we should get high quality of dominant follicle, which we can receive mature oocyte because we need mature oocyte for this technique. And of course, also endometrial fracture. So if patient has chance to get an embryo transfer still, so for us, there is no age limit. And of course, if they still have potential for egg receiving, but if still they have problem for the embryo transfer, but they will use surrogacy, still also possible to use pronuclear transfer.
Thank you. The next question, how would I know that I need this? How would I know that I need pronuclear transfer?
Okay, of course, for that we need IVF history. So we are trying to check their history, patient history, at least if they have several trials, so without reason embryo stop the development, or there is no any blastocyst, or always after PGD they are getting aneuploidy, they cannot find embryo for transfer. So in this case, pronuclear transfer is helping. Of course, we cannot suggest the pronuclear transfer if they don't have any history which they can give us. But of course, if they have high maternal age, or if they have some genetic story in their family, so this is another option which we can talk about. But we need to get some data from their IVF histories.
Thank you. I can add that we can organize a Skype consultation with our fertility specialist, with our embryologist, and you can send all the medical documentation, and after that we can arrange a meeting, and our specialist can recommend the next step of the treatment. So our next question is, can I ship my egg cells to you and after that do the transfer in your clinic? Or it's better to come to IVMed to retrieve eggs and you will use fresh eggs, not frozen?
So in this process, it's just important to use fresh donor eggs always, because fresh donor eggs is not fragile. So because basically we need to use donor eggs. Actually, we need only pronukleus of the intended parents. So of course they can move their frozen egg, but almost we prefer fertilized frozen eggs. So if they freeze in wherever they are doing IVF cycle, they don't need to come to do all process with us. If they freeze or vitrify zygote, so that will be more advantage, because we only will thaw these oocytes and just we will take pronukleus and to transfer to fresh donor. So actually, basically, they don't need to be physically here.
Thank you for your answer. The next question, in general, do these techniques increase the chance of success of IVF? My wife asked about abortion rates in particular.
Of course, I mean, this is the only alternative techniques which we can suggest for the egg donation. There is no any other techniques which is working and helping the couple. According to my experience, of course, number is still not enough. I mean, I cannot say we are doing 1,000 cases, like we cannot give a big data because we are choosing patient for the pronuclear transfer really detailed. So we have to catch some kind of exact symptoms which we can believe that we will get success. So as I tell you already, so if there is a mitochondrial disease, if there is really poor quality oocyte, if it is polycystic ovary syndrome deeply and they tried 4 or 5 IVFs, and if there is no embryo development in several IVF, so that is the perfect candidate for the pronuclear transfer, and mostly we get success. Okay, pregnancy is still question because I cannot talk about endometrial factors. This is a different field. But still, after these techniques, we can like we can give a personal guarantee, like we will get for sure blastocyst. Because many patients, they don't have any blastocyst in 5-6 IVF attempts. Even they are giving, especially on polycystic ovary syndrome, they give 30-40 eggs and finally all is getting arrest on the cleavage arrest on third day or fourth day or second day. So they don't have any blastocysts. For such cases, it's a perfect solution and quick solution.
Thank you for your answer. We have the next question. How about the cost with surrogacy? Actually, I can answer that question. It's 43,000 euros. And if you are interested in the program, you can leave us your email and we can contact you and send you the program. So we have a special program with surrogacy and pronuclear transfer. The next question. Hi, my husband and I want to do this transfer, but still worried. Are there any risks for the patient? Are the protocols of preparation are different if you transfer the embryo after pronuclear transfer?
There is no any risk because there is nothing different than regular process. So what we are doing, only difference, we are using like a different surface. We just use energy of the donor oocyte. So basically, still genetic material is from patient. So as I said, that can look traumatic for the oocyte, but finally oocyte will continue develop, will get the embryo. If we are talking possible genetic problems, actually from this technique, it's impossible to get mitochondrial disease. This is the first. And second, even if it is some genetic problems, we are not doing embryo transfer after pronuclear transfer without NGS test. So we analyze according our pronuclear transfer package, we analyze for all embryos for NGS testing all chromosomes. So if we find, of course, some genetic mutation or problem, we don't transfer this embryo.
Thank you. Our next question, actually, it's kind of the question that we had before, but still, can we freeze eggs, then ship to do this? If so, what day should we freeze them?
As I said, there is no risk if they freeze oocyte or fertilize oocyte. So I prefer to freeze fertilize oocyte. Of course, this is less traumatic because if they send frozen oocyte, we should tow them. After towing, we should fertilize them. So of course, this is a more traumatic than fertilized oocyte. If they just freeze the oocyte in the first day of the development after the fertilization, so that will be great. They can send safety and transport or mechanical, any technique will not affect the quality in this case.
Thank you. Our next question, do we need to do NGS with this? Also, do you do NGS in your clinic or sending them somewhere as well, like any other clinic in Ukraine? So this is the first part of the question.
Yeah. Okay. Firstly, of course, we don't do embryo transfer without NGS testing for pronuclear transfer program. So every blastocyst which we receive from the patient after pronuclear transfer, they must be tested for NGS. This is the first. And if we are talking, IVMed clinic using their local NGS testing. Actually, we are collaborating with one of the biggest IVF genetic laboratory group in Turkey. We are able to make any genetic test, which is still not possible to test in Ukraine. Not only NGS testing, but also carrier screening testing. Also, we are doing monogenic disorder testing. So many different genetic testing through embryos or blood. We are able, as IVMed clinic, to test and to give quick answer. So, for example, for NGS testing, mostly there's a main problem for the patient. So they are waiting a month, like 20 days. We are receiving mostly result for 5 to 7 days after biopsy for the NGS testing.
Thank you. And we have the next question. Do they have to be embryos to do this, or eggs and sperm freeze separately to do this? This, I think.
No, of course that from embryo we cannot get nucleus. So that's first way. They can send oocyte, frozen oocyte and frozen sperm, so we can tow and fertilize them here in IVMed. Or second way, they can just make a punction over there to get oocyte, and patient can give sperm. They can just fertilize and freeze. They can send us ready oocyte. So we don't need embryos. We need zygote or oocyte.
Okay, thank you for your answer. I just need to do a quick check if we answered all the questions. It seems that. Thank you for your nice presentation and answers to the questions. It was really informative, I think, for all our patients. And I'd like to invite our guests to our next webinar. We have weekly webinars every Friday. So see you next Friday and have a nice weekend.
Have a nice weekend.
Bye.